And we'll move to our last talk, which is Dr. Mario Lacouture, who has done a lot of research in skin toxicities. And kind of unlike myocarditis, which is fortunately rare and very severe, many patients will have cutaneous toxicities from immunotherapy, and we keep Mario quite busy with referrals all the time in that regard. And I think he'll be sharing some of the experience with us today in his clinical practice with dealing with this problem.
Thanks, Mike. Thank you very much for the invitation. It's really an honor and a privilege to be here today. And I will be presenting our issues with skin toxicities. These are my disclosures. As a matter of background, I would like to emphasize that the skin is an immunologic organ. As you can see here in this intravital multiphoton microscopy in live mice, you can see that at every layer of the skin, you will see a high density of cells of both the innate and the adaptive immune system. Therefore, it is no surprise that the skin is one of the organs which is most commonly affected by immune-related adverse events. And it is also one of the first to be affected. As you can see here in this cohort of over 440 patients treated with IPI and Nivo, grade 3 to 4 events occurred with a median onset of about 3 weeks, those that affected the skin, which was earlier or at least more rapidly identifiable than toxicities of other organs. In addition to that, in the pivotal study of atezolizumab and Abraxane, you can see that a rash was the most common toxicity that was identified in these patients compared to every other organ system. So certainly a common event in our patients. Another important aspect of skin toxicities is that we have the luxury of being able to evaluate these events from a clinical perspective and differentiate them into various phenotypes. Jeannie Wu and Greg Phillips were research fellows at our service, which analyzed over 420 immune-related cutaneous adverse events and found that there were a variety of phenotypes that affected these patients, as you can see here, such as a maculopapular rash, pruritus, a lichen or psoriasiform rash, or a bullous disorder, which appeared to vary depending on whether the patients were receiving a PD-1 or PD-L1 inhibitor, highlighted here in blue, compared to a CTLA-4 inhibitor, highlighted here in red. In addition to that, other studies have found that perhaps underlying pathobiological mechanisms of these events may also differ. In this cohort of 102 patients treated with CTLA-4 or PD-1 inhibitors, it was noted that patients that carried the 1101 class 2 allele were protected against itching or pruritus when compared to patients that did not have this allele, suggesting that perhaps there are indeed specific immune mechanisms that underlie the distinct phenotypes. In addition, a prospective evaluation of cytokines in patients with grade 3 or worse immune-related adverse events also showed that there were a variety of cytokines and chemokines that both were part of either the Th1 or Th2 or Th17 immune pathways that underlie these mechanisms as well as these toxicities. And in dermatology, we have been familiar with these types of immune mechanisms because there are conditions that affect the population that are very frequent, such as psoriasis and atopic dermatitis, that have been very well studied. So a paper from Jeff Bluestone's group on immune-related adverse events highlighted that perhaps the mechanisms underlying these events were primarily of two varieties, either autoinflammatory, mediated by cells of the innate immunity, and mediated also by cytokines and soluble factors. And there is evidence to this, such as the increased expression of CD8-positive T cells, IL-6, and neutrophils in affected tissues as well as in peripheral blood. And conversely, there is evidence for autoimmune mechanisms underlying these events, as there is an increased abundance of anti-bullous pemphigoid antibodies in the blood of patients affected with these toxicities, also increased IgE, as well as increased presence of CD19 low positive B cells in patients that develop these toxicities, highlighting that these toxicities may be mediated by distinct pathways. Therefore, in dermatology, we follow a principle which is treated the way it looks, And as such, the maculopapular rash, because it is thought to be a consequence of nonspecific inflammation, likely Th1-mediated, responds very well to oral corticosteroids, and only about 20% of patients are corticosteroid resistant for this toxicity. Conversely, patients that have psoriasis-like phenotype, as seen here, can be treated with commercially available agents very effectively, as shown here, as in this patient with a PD-1 inhibitor psoriasis treated with the anti-IL-12/23 agent ustekinumab. You can see a complete resolution of the rash with no steroid use. In addition to that, as it pertains to the Th2 pathway, this patient with renal cell carcinoma treated with a PD-1 inhibitor presented for this severe case or grade 3 atopic dermatitis-like rash with intense pruritus, as you can see here from all these scratch marks. The patient was treated with the commercially available agent dupilumab, which is an IL-4 receptor alpha inhibitor approved for atopic dermatitis. And after only 2 cycles, the patient was now free of pruritus, and as you can see, the rash had markedly improved. Another case I'm showing you here, this is a patient that developed one of the bullous disorders or bullous pemphigoid associated with IPI and NEVO. The patient had not responded to systemic steroids, but was treated with rituximab, and by blocking CD20, you can see that there was a significant improvement after 4 weekly administrations of this agent. One of the points I would like to make, because this is likely the most frequent reason for consultation, is patients that present with severe itching or pruritus. And Greg Phillips, which is highlighted here, analyzed 79 patients that presented with severe itching. In dermatology, we like to give very sophisticated names to simple things, so we call itchy bumps prurigo nodularis, as seen here. And what Greg found was the impact of this itch, that you do not see a rash, was as significant as in patients that had an itch associated with a rash. And this is very important to keep in mind, because itch can be a severely disabling adverse event, and it is very hard for us to empathize when we cannot really see what we are treating. So we had many patients referred for this, and we really didn't know what to do, because the majority of patients did not respond to antihistamines or topical steroids. So we went back and looked what has been done in other specialties as it pertains to pruritus or itch. And what we found is that in a rat model of itching or pruritus, these rats are treated with capsaicin, which is the ingredient in chili peppers. And all of these that you can see here are scratch marks that are self-inflicted by the rats. And when these rats are treated with the oral agent gabapentin, the GABA agonist, you can see that the scratching behavior was significantly reduced when compared to the controls. And these investigators also did functional MRIs of these rats. And what they found was that the areas of the brain that were highlighted in the rats that were treated with the gabapentin were decreased, as you can see here, in the dark line when compared to the rats that were treated with the capsaicin, suggesting that a centrally mediated role from the GABA agonist was able to reduce the pruritus or itch. And in humans, it has been demonstrated in the uremic pruritus population that pregabalin is more effective when compared to the antihistamine doxepin in terms of mitigating pruritus by reducing a visual analog score to 2.1 compared to 4.2 in the doxepin arm. So based on these observations, we treat patients in such a targeted fashion. And this is a figure from Greg Phillips and Jeannie Wu's paper that came out this week in JCO. And of 331 patients treated for immune-related cutaneous adverse events, you can see that the majority of these patients, the length of the bar indicates how frequently specific intervention was administered. So 100% of patients received topical agents, and 74% had either significant or moderate improvement in their toxicity. Similarly, you can see here, for all types of events, antipruritics were effective in about 81%, and immunomodulatory systemic agents in about 75%. When you look at this specific phenotype, you can also see that some interventions are more effective than others. For example, in pruritus, as mentioned previously, a GABA agonist was likely more effective than other agents such as topicals and immunomodulators such as corticosteroids, and this difference was statistically significant. And for the maculopapular rash, topical agents appear to be sufficiently effective in the majority of patients, and there was really no need for these patients to receive systemic immunomodulatory agents such as corticosteroids. About 20% of these patients that were evaluated by Greg and Jeannie did not respond to systemic corticosteroids. And in these patients, what they identified was that there were increased levels of certain biomarkers that correlated with greater toxicity, such as increased eosinophils, IL-6, IL-10, and immunoglobulin E. To us, the increased presence of IgE was particularly attractive because this is something that we can block with a commercially available agent called omalizumab. This agent is available for urticaria as well as asthma, and Dulce Barrios, who's a research fellow at our service, has analyzed 43 patients with IRCAEs with increased IgE in the blood and has found that in these heavily pretreated patients, about 80% of these patients responded to omalizumab, 300 milligrams injection subcutaneous every 4 weeks when they had not responded to corticosteroids or antihistamines. So based on these observations, we are currently in the preparation of a prospective study. To show you an example of the benefit of targeted intervention, this is an example of a patient referred from an outside institution, a 58-year-old lady treated with Ipi and Nivo for her melanoma, then on maintenance Nivo. She developed the bullous pemphigoid associated with these therapies. She had been treated with prednisone, mycophenolate mofetil, even rituximab. Her IgE levels were about 400, slightly elevated, and after one administration of omalizumab, you can see the improvement in all of her blistering lesions, which had not been possible with all those other interventions. Conversely, patients with high TNF-alpha that have not responded to corticosteroids, we treat with infliximab. This is an example of a patient with a lichenoid rash that had not responded to corticosteroids, and after 2 administrations of infliximab, you can see that there is a marked improvement. So based on this, we feel that a targeted intervention for these events is the way to go, as described previously by other speakers. And finally, since as Matt Hellman described this morning, that most of these patients, at least in lung cancer as well as other malignancies, will be receiving immunotherapies at some point during their disease, it's important to remember that the IRAEs will not end once the patient's treatment ends. And to emphasize that point, this was a cohort of patients from Jim Harding and Paul Chapman, and what they found here was that in 13 patients that had received ipilimumab and progressed, and then they received the BRAF inhibitor vemurafenib, 4 out of these 13 patients developed a grade 3 maculopapular rash, much higher than was expected. And we are seeing this every day. Patients that finished their treatment with a checkpoint inhibitor a year ago and only now are developing many of the immune-related cutaneous adverse events. So it's important to keep this in mind. Thankfully, in this case, all of these patients were rechallenged with no additional consequence. And just to end on a good note, since it's the end of the meeting, I would like to say that immune-related cutaneous adverse events do have a silver lining, and many studies have shown this, especially in melanoma. But a recent paper in this week's JCO showed that it also was the case in urothelial cancers, in which patients that present with skin toxicities do appear to have a prolonged PFS as well as a greater overall survival as seen here. And this has been demonstrated, and I think this emphasizing this to patients gives them comfort as to tolerating these events while we find better ways to mitigate them. So to conclude, cutaneous immune-related adverse events are frequent. We are focused on targeted interventions using CD20, IL-6, IL-5, and IgE blockers. And we believe that this is important to manage because the quality of life and consistent dosing and the knowledge on dermatologic prescriptions is limited. The impact of these immune-related adverse events will increase in importance with combination studies. We know that the incidence is greater when you combine Ipi and Nivo, but with the combination of any other immunostimulatory agent, it will be worse. And of course, as patients live longer, they will emphasize much more these quality of life issues. So I would like to thank the supporters of our work and thank Dr. Postow for the invitation, and thank you very much for your attention.
Questions for Mario? I know we're getting to the end. I just have one thought, Mario, or really a kind of a question is, how are you designing the omalizumab study? Are you selecting patients with elevated IgE specifically or certain kinds of skin toxicities? And in keeping that in mind, what's your general thought on how do we do studies in patients that are developing either cutaneous toxicities or these other immune-related adverse events to really try to see which immunomodulator is best? It's a hard area, I know.
Yes, it's a good question. So how do we select the patients to include? And this is why we do this retrospective analysis to try to tease out which would be the best candidates. For the anti-IgE antibody, we are selecting patients that have upregulated IgE in the blood and that have a phenotype that is consistent with what is known about increased IgE. In other words, they have pruritus, and they present with any of the diseases such as atopic dermatitis, bullous pemphigoid, or urticaria that have been associated with increased IgE in the non-cancer population. And I think that would be the way to go with other conditions as well as other targeted therapies, is to find a biomarker that can really be quantitatively measured once patients are treated.
Great. Other questions? Okay. Thank you, Mario. Okay, great. We made it before 5 o'clock. So thank you guys all for your attention. This is an annual meeting, the alumni group. We have this every year. This is the 44th one, and this is the first time, to my knowledge, that this has been on kind of a therapeutic modality rather than a specific disease. And I think we've seen a lot of the challenges and controversies in the field of immunotherapy, both from how long do we treat, where in the treatment paradigms these diseases need to be treated with immune therapies, and then this afternoon really kind of plunging more deeply into each different specific toxicity that can happen with these treatments and how we really need to work with our multidisciplinary clinicians and colleagues in terms of understanding the side effects better. So with that, I will close. I hope people can join us tonight at 7 o'clock at the JW Essex House on Central Park South. It's going to be the alumni dinner dance, so we'll have some awards and celebrations there. And just before I also move to that, for those of you that can't attend, I also just want to thank Keith Yearwood, who's here, and his team, Jennifer Cruz and others, for helping put the meeting together today. Really couldn't do this without you, Keith, and I really appreciate your help with the organization. So thank you all.